मोठं करा. मोठी स्लाइड करा.
You can go live now, Samriddhi.
Good evening, everyone. I welcome all the participants and I really apologize for the delay because sir had an emergency and that is why the session is delayed. So I welcome you all to this webinar. The topic of this webinar is Vonoprazan, Unveiling Vonoprazan, a new age acid blocker. And this webinar is brought to you by Hetero Healthcare. So with this, I also welcome Dr. Shashikant Pawar. Dr. Shashikant Pawar is MBBS MS FIAGS, associated for 2 years with Shrikhande Clinic with Dr. V.N. Shrikhande. Dr. Shashikant Pawar started his practice in 1988, specializes in laparoscopy, gastro-colo ERCP, and gastrointestinal surgery. And doctor is associated with Pawar Nursing Home, Satara. So with this, I hand over the session to Dr. Shashikant Pawar. Sir, please continue.
Thank you, madam.
Thank you, sir.
Good evening, all of you. Today's my topic is potassium competitive acid blocker, that is a PCAB, very new drug and in a treatment of acid related diseases. Yes, it is a totally new drug. It is not the old wine in a new bottle, but it is a totally new drug. So it is a Hetran Vonoprazan. So in an era of no medicine, it was a situation like a suffer and land into a complication. So with the advent of the medical fraternity, new inventions they occur, and that in those times only the diversion surgeries like a gastrojejunostomy, vagotomy was there. In the era of a antacid, then the era of H2 blockers, then the PPI, and then the now PCAB, that is a Hetran. So now the prevalence, if we consider the prevalence of the peptic ulcer disease, peptic ulcer disease, it is almost about 39 and 37 patients in a GRD and PUD respectively. Out of that, around duodenal ulcer, the percentage is around 10.5, gastric ulcer 9.9, and peptic non-ulcer, the specified disease is around 16%. So before we go to what are the challenges of the PPI, we have to know that what is the acid. Acid is secreted by the stomach from the parietal cell mass, and it is the mechanism by which the mechanism, that is the chloride shift from the acini in a normal physiological manner. It is a chloride shift, and parietal cells they secrete the acid secretion, and there is a enzyme, then hormone, then cephalic phase, then gastric phase, then intestinal phase. All are responsible for this chloride shift, and normal H ion are secreted into lumen, and simultaneously the chloride ion is secreted, and both come together and HCl is formed. So the normality is around 0.01%. The normality acid is secreted, and daily it is around 20 ml to 200 ml, and it increases during the food time when the food is inside the stomach. So now what is the function of the acid? The function of the acid, primary function is to digest the food. It starts in the stomach. It breaks down the protein when the pH level reaches up to the 3.5 at a maximum reduction in the acidity and toward the alkalinity. That time the pepsinogen gets converted into pepsin molecule of the local hormone, local enzymes, local secretions, and that add to the acid secretion. The second use of the acid, gastric acid is to convert it to the molecule, small molecule, so that in further when it reaches to the small intestine, it gets absorbed easily, like say zinc molecule, iron molecule, B12 molecule. With the help of the intrinsic and extrinsic molecule, when they combine, the B12 get absorbed. The second advantage of this is it kills the bacteria uh, the coming through the food. So these are the effect, and with the feedback mechanism, when the distension is there, acidity is more. When the food reaches by the second, that is called as a gastric emptying. When it reaches to the duodenum, it releases the hormones, say CCK, secretin, GLP-1, say peptides from the intestine, that gives us the backfeed signals to the pancreas, stomach, and that also leads to a control of the acid secretion. There is another hormone that is a chief cell. From there, the gastrin is released, and the gastrin, it gets absorbed. That is a hormone, get absorbed by the vessels and comes at the target organ, that is a parietal sac. That also helps to increase the acid secretion. So we know the alcohol. Alcohol is if we consider the alcohol, it is an irritant. So irritant causes the more acid secretion, and say there is no protection. It gets absorbed, the alcohol gets absorbed from the stomach mucosa and reaches to the stomach. So if you take a plain alcohol, it is a harmful. It is it causes the gastritis. It causes the chronic gastritis, and there are so itself. So alcohol has got a irritative effect. Alcohol has got the injurious effect and to the gastric mucosa. So before taking alcohol, my advice is to don't take any PPI, take a mucosal protective agents. So now coming to the challenges of the PPI. So the PPI, those are the drugs like say pantoprazole, rabeprazole, esomeprazole. They act only on an activated proton pump. PPI are acid liable. They get degraded in some part, and so it is not 100% available. So it has to be entry coated, and it takes to start the maximum effect. It takes time, almost say 3 to 4 days, and it is the degradation by the influenced by the cytochrome P4 P450 and polymorphism, and it is an incomplete symptoms relief after the first dose. So, and it has got a slow onset action, and there is a inadequate control of nocturnal acid breakthrough. That means it is not achieved the 100% relief with the PPI. There is a in between acid secretion is there. So this is the challenges. These are the drawbacks. These are the limitations of a PPI. So now what is the acid we consider? Now we have to take before going to the PPI in a detail, that to a PCAB will go a very brief what medicines available in the market. First is the non-medical era was the only go for the operation, diversion operation, vagotomy. That vagotomy is also responsible for the acid secretion. So antacids are the second largest group in the era of say before 90, before say 80. So only available medicine was the antacid. Antacid acts by the neutralization of the acid, and we have to take the very frequently, then say almost hourly, 2 hourly, 3 hourly. If the relief is there, you can increase the time. Then the era of the H2 blockers. H2 receptor blocker. These are the receptors present on the parietal cells, and these are the antagonist receptors. Antagonists. Say it is a histamine antagonist, so it limits the acid secretion. In those era, ranitidine was there, cimetidine was there, famotidine was there. Then the second era, which started from the 88 onward, the era was say omeprazole, say rabeprazole. These acts by These acts by say PPI, that is a proton pump inhibitor. So there, at the canaliculae level, the acid secretion starts, but it is a competitively, irreversibly, it acts, and acid secretion is slowed down. So rather, acid secretion is controlled. Then now the era of next to the PPI is the era of PCAB. That is a new class of drug evolved, potassium competitive acid blocker. That is a PCAB ETRA. So vonoprazan is the chemical name, first in a class of potassium competitive acid blocker. It was approved in Japan, Russia, and USA. Almost 15 years it was available in Japan, recent years in Russia, and recently in USA. So why we call it is a superior PCAB over the other PPIs? Yes, it has got a differential mechanism action. It starts the action from the day first dose itself. Minimal drug reaction. Administration is a administration we can give even with the after food, and longer it has got a definitely a longer duration of action in the form of to increase the pH. So again I have to add something. See, these are the acid related disease. What is this acid related disease? That is commonly we call as a acid peptic disease or the dyspeptic symptoms, then uh, GRD, then gastric ulcer, then duodenal ulcer, then some the enzyme secreted in the hyperplasia of the gastric tumor, then Zollinger-Ellison syndrome, then mitotic lesion. These are the acid-related diseases. So when we want to come to a conclusion that some definitive disease is there, we have to go for the investigation. Say like a test and treat, test and treat, test and treat. If the clinically you are dealing with the say no such a type of disease, but we have to give the PCAB and other medicines. If the disease is there, some symptoms are there, blood vomiting is there, marina is there, then we advise them go for upper GI endoscopy. In a history, the insulin test, the histamine test, then acid secretion test. These are the now. Instead, we now measure the pH measurement of the stomach, and which is getting reflux into esophagus. That is a pH measurement, pH study. So that also helps for the. And lastly, we go for the motility study. So these are the investigative process. We have to think, and then we have to go for the definitive medicines. So if we are dealing with the say NSAID, steroids, then some other medicines, which increases the acid secretion due to the response because of their irritative nature, locally irritative nature. There is another defined, and that it was invented by the Australian people. They got the Nobel award. So they have proved that in a stomach there are the H. pylori bacteria are there. They are responsible for the ulcer, gastric ulcer, duodenal ulcer, and it is a precancerous condition. In that case, the bacteria they utilizes the urea with the help of the urease enzyme and produces the ammonia in a local area in the stomach mucosa, duodenal mucosa, and it erodes the mucosa landing into the gastric ulcer, duodenal ulcer. So these are the precancerous condition. Another the acid is there of the pernicious anemia. That is also there is no acid, so there is no ulcer. It is a statement that is when there is acid, there is a ulcer. When there is no acid, so there should not be patient should not suffer from the. So that condition is present in the pernicious anemia. So now we'll go to the how the action takes place by the PCAB. It is a competitive competitively and reversibly blocks the potassium binding site of the gastric parietal cell, individual cells, and it activates all phases of these cells. Active phase, like a PPI, it is only active phase. PPI they gets activated, but here it acts on all sides and it suppresses the gastric acid secretion. Diagram shows how it works. So this is a comparison of the conventional PPI and Vonoprazan hetran. The hetran has got a multiple site all over the parietal cell mass, and it definitely helps for the acid secretion in mechanism. So action starts with the first dose. It inhibits the active and inactive proton pumps. Thus, the exhibits the anti-secretory action on a first dose itself, and steady state concentration is achieved on a first day. PPI requires, on the contrary, PPI requires 3 to 4 days. It maintains the pH for a longer duration. Vonoprazan is acid stable. Like a PPI, it doesn't get degraded itself into the stomach because of the high gastric acid. It doesn't require activation by the stomach acid. It maintains pH near or about 4 for a longer duration. So it is maintained by the use esomeprazole up to 61%, rabeprazole up to 65%, and hetran vasopressin up to 83%. And it prevents definitely nocturnal acid breakthrough. That means it maintains the low acid level inside the stomach. Minimum drug reaction as compared to the PPI. The PPI, the vonoprazan is metabolized in the liver through the CYP3A4A. PPI are metabolized by the CYP2C19. Thus, there is a risk when the omeprazole, like other PPI, they are given simultaneously. There is a clopidogrel's action, that is a ecosprin action is that gets degraded, that clopidogrel, ecosprin, and there is a incidence of more bleeding, and so that proves that there is an interaction with the PPI and it is not with the vonoprazan hetran. Vonoprazan has got a minimal side drug reaction. Administration, irrespective of food timing, it can be given with the stomach. That means you need not be a empty stomach. If the food is there, you can give the medicine, and it food never interferes with the action of the omeprazole hetran. So the benefits are more with the hetran vonoprazan. It starts with the action starts with the suppression of the acid skin with the first dose, rapid and sustained action, minimal drug reaction, prevent the nocturnal acid breakthrough, and maintain the pH on a higher side, and can be taken with the food. So again, the same information. Comparison with the PPI, it is acid label, needs enteric coated. It is a PPI is a HK80 base inhibition, and then studies that is a 3 to 4 days it is required. In case of the PCAP, it is a zero hour, or when you take the medicine, it starts the action. It is a acid stable, and there is no any protecting for the tablet. It is by the both active and inactive parietal cell PPI, and it is metabolized, and it gives us a longer duration of action, stronger efficacy, and faster action. We'll skip this slide. So dosage wise, see, as I told you, the acid related diseases are reflux esophagitis, that is the stomach content with the acid get reflux to the lower esophageal sphincter into the esophagus, causing the esophageal mucosal injury. It may be associated with a lax cardia, hiatal hernia, motility disorder, achalasia cardia. So there is a reflux esophagitis. In that case, you can give the 10 milligram, 20 milligram vonoprazan hetran. Gastric ulcer, it is again produced in a low acid media. So we can give the lower dose 10, 20. Duodenal ulcer, these are the high acid secreting diseases, say more acid is secreted, so it requires the more. So you can give the double dose or the 20 milligram up to the maximum 20 milligram once a day. Prevention of the recurrence of gastric ulcer during the NSAIDs administration. So see, all the listeners are the medical, orthopedic surgeons. So prophylactic, we have to give the the PPI, PCAPs, and prevent the acid-related diseases because the your patient receives the NSAID, sometimes steroids. So I told you the H. pylori bacteria also is responsible for the duodenal ulcer, gastric ulcer, and sometimes malignancy of the stomach. So in that case, it is now the proved beyond with the papers giving the information of a use of the PCAP. That also helps 20 milligram twice a daily. So this is a comparative study in a case of the impaired renal function, vonoprazan recommended dose. Even though there is a renal impairment, you can give the required dose in case of erosive esophageal H. pylori infection. So even in a hepatic impairment is there, compensated liver diseases, say like a commonest is a liver cirrhosis, and hepatitis B, liver cirrhosis, hepatitis C, liver cirrhosis, autoimmune diseases. And it is recommended even in all child C, child C. The child C is a higher stage disease, and usually those patients require the hepatic transplant. So there is no dose adjustment in case of the liver. Now we'll go to the clinical cases, papers. Before that, I will give my personal. See, I regularly go for the gastroscopy, and I do, and I see the duodenal ulcer, gastric ulcer, and couple of months back, I had a case of a bleeding duodenal ulcer. In that case, Hetran Vonoprazan was given on the first day. Other mucosal protective drugs and prokinetic drugs, and Hetran was the HERAP was given to prevent the simultaneous to prevent the acid reflux into the esophagus. So he was given this was my personal experience, and he was admitted patient. The blood transfusion was given. He was having this thing echosprin. So we have to stop that echosprin, and we have to go for the endoscopy, find out the duodenal ulcer bleeding, and start the medicine. He got the relief. And yes, definitely, Vonoprazan Hetran gives a very excellent result. So we come to the now the various journal study. So Vonoprazan given one of the most promising treatment option for the patient with the PPI resistant GRD. So there are condition tachyphylaxis is a condition where even if we increase the dose of the PPI, but the patient doesn't get the relief. So increasing the dose, say 20, 40, double dose, 80 milligram. Sometimes the PPI resistant cases we come across, and in that case, Hetran has proved the effective in a GRD. So this is JNM journal that gives the PCAP is an acid blocker, new era for the treatment of acid-related diseases. Vonoprazan was shown to overcome the weaknesses associated with the conventional PPI. Definitely, it is a superior to the PPI, and it is a suppression in acid secretion is a very high at even at a night, and it has got a very effective medicine, and there is no reaction it has proved. So the another paper was published. It shows the acid inhibitory effect of the vonoprazan 20 milligram administered daily for 7 days. It was compared with the esomeprazole or rabeprazole in a healthy Chinese patient. They have shown the vonoprazan Hetran exhibited significantly greater acid inhibitory effect than the esomeprazole and rabeprazole. See, it is a novel drug. See, the another journal, they have mentioned the management of the gastroesophageal reflux disease, that is esophageal disease. Here also because of the continuous reflux for a longer duration of the reflux, the acid comes into the esophagus and there occurs the grade 1 esophagitis, grade 2 esophagitis, grade 3 esophagitis, and that ultimately lands into the Barrett's esophagus. The Barrett's esophagus is a condition where we consider it is a pre-malignant condition. In that case also, vonoprazan has shown the excellent and therapeutic effect on the erosive esophagitis and preventing the further progress of the disease and maintaining the 24-hour pH reaching up to the 4, and it is helpful drug in a GRD. So this is another study, expert opinion, drug safety, 2023 January. They have come to conclusion that no data of safety concerns were reported for the vonoprazan for the prevention of the secondary ulcer and bleeding in a patient receiving the long-term NSAID, and they have shown that it is a vonoprazan hetran is effective for preventing NSAID related peptic ulcer recurrences in this new world study. So clinical gastroenterology and hepatology, they have shown the vonoprazan reduce the heartburn symptoms in case of GRD and with the benefit of appearing to be benign as early as first day of the therapy, and the treatment effect persisted after the initial 4 weeks compared to the placebo control study, and the two vonoprazan doses 10 and 20 were similarly efficacy. So I can tell you my experience in case of the duodenal ulcer. Yes, definitely it requires 4 to 8 weeks of treatment. That also 10 milligram is helpful, 20 milligram is helpful. If we go by the investigation, that is a endoscopy, pH study, then motility study, you can give the combined treatment in the form of the antacids, HERA, then PCAP, omeprazole, hetran, and prokinetic drugs, then sometimes antacids. There are drawbacks in relation to the antacid. The aluminum, then these are the say diuretic action, some calcium, they have got when they get absorbed, the calcium stones are formed. In case of the antacid, you have to take the continuous very frequently. But in case of the vonoprazan compared to the antacid, the dosage you can take once a day, 10 or 20 milligrams. So definitely it helps in acid related diseases. I conclude. If any questions are there, yes, please feel free to ask me questions.
Sir, there are a few questions, like how vonoprazan is superior to PPIs when it comes to giving prescribing it to patients who are already on NSAIDs, because these patients are always on having some pain, so they are on NSAIDs. So how vonoprazan is superior to PPIs?
See, it has a single dose we can take with the food, and there is a drug reaction, and it has got a no drug interaction in the form of, say, you can give this drug along with the ecosprin pulpitagrade. So the complication rate, PPI, ecosprin pulpitagrade, they have got the bleeding tendency is more.
Yes.
Yes. So definitely it is a very superior drug compared to the PPI, and then you can use with the help of the investigative process. No, not necessary for every patient you have to go for the investigation. If the symptoms starts, that is a test and treat. Test and treat. If the symptoms are there, then you can consider for the investigations. Then you can compare. You can consider for the hetran vonoprazan. If the GRD is there, you can add to the vonoprazan, hetran, the HERAP. So that helps definitely. And adding the prokinetic drug, adding the mucosal protective drugs, definitely it gives you a 100% relief.
And how long it can be safely prescribed, sir?
See, if only the erosions are there, if only the gastritis is there, In that case, 4 weeks treatment or other 7 to 10 days. If the symptoms are there, erosion, you can increase up to 4 weeks. If the definite gastric ulcer, if the definite duodenal ulcer is there, you can give around say 8 weeks.
Okay. Right. That was a very interesting and very informative session, sir. So I really thank you from on behalf of Hetero Healthcare for giving such a wonderful session. I also thank all the attendees who are listening carefully, attentively. So thank you very much, everyone. Have a good day.
Thank you, madam.
Thank you, sir.
Okay.